Thank you very much. It's lovely to be here, and I've been asked to talk specifically around dignity and end of life. So thank you to our previous two speakers who sort of helped think about this topic. So I'm going to talk a little bit about context so you understand where I'm from in Scotland and the sort of work I do. And then we'll start to think around the concept of dignity and hopefully give you some practical examples that people can take back to their own long-term care places. So just a little bit of my team. Actually, so Glasgow's a fairly big university. We have a fairly big school of medicine, big school of dentistry, a smaller school of nursing, and even smaller research. I joined the university 7 years ago, although I'd done my own doctorate there, and starting research really from scratch. So growing PhD students, postdocs, and some tenured staff. So these are some of my PhD students and postdocs in a very rainy Scottish day a couple of Novembers ago. So you probably can tell just a flavour of the pictures of them coming from all parts of the world. So people come, Bella in the sort of boutique came to me from Indonesia. She's just submitted her PhD. San from Thailand. Bahar actually came from Palestine. That was really tricky for him when he was ready to data collect because he couldn't get back into Palestine from Scotland, so he had to data collect in Scotland. Just a little bit about what we do in my team in Glasgow. We do have a big program around dignity and end-of-life care. We're also interested in symptom management. Big part of my work is building research capacity, particularly from nurses, but not just from nurses. And also this interest in palliative and end-of-life care in resource-poor and marginalised communities. Just some examples you heard in the bio bit about some of my work. So one of the interesting things, we've done a big project around the role of the nurse in multimorbidity. Multimorbidity is a growing problem, as we all know, around the world. And yet we still treat people, and not just in Scotland, in other parts of the world, according to their index disease, their main disease, rather than thinking that the person has needs related to lots of different illnesses. So we heard a little bit before about death. It's funny, we still, we're in 2023 and yet we are all going to die. Every single one of the people in this room, I can't tell you you're all going to have cancer, but you are all going to die at some point. It is something that is going to happen to all of us. And yet we're still so afraid of it. I mean, it's often, it doesn't really matter what culture or country you come from. People on the whole are afraid of death. So in this infographic, this is a UK infographic, but only 32% of us think about death and dying. Me, every day, but then that's my job. And only 27% of us have talked to people about our funeral wishes, and even worse, only 7% thinking about our preferences of future care. And that's so important. We have a big movement in Scotland around writing down our wishes of future care, and yet there's no way it's universal across Scotland. Many people will know the definition of palliative care that most of us in the world work to, and it's around improving quality of life for anybody facing life-threatening illness. Just a little bit of context so you can understand about palliative care in Scotland. We have 18 hospices, 16 hospital palliative care teams. We have CNSs, so that is a nurse specialist who work both in the hospital, the hospice, and the community. We also have consultants in palliative medicine who tend to work in our hospitals or hospice, very few specifically in the community. But we do only have 2 professors of palliative care. My colleague Mari Fallon, who's a professor of palliative medicine based in Edinburgh, and then me based in Glasgow with a nursing background. So just to give you a little bit more context of the country and where this map doesn't actually have our islands on it, but it's just to show you that most of our areas, not surprisingly, this is most of our concentration of care is in what we call the central belt, the bit from Glasgow on the west through to Edinburgh on the east. Our highlands and our islands much less populated, and yet so the bit that I work in Glasgow is the biggest area in Scotland. We have, just to give you an example, we have one of the biggest hospitals in Europe in Glasgow. We also have 6 hospices, and then we have 2 children's hospices in Scotland, and one of them is located in the rural Glasgow area. But so many people here in this room, I'm sure you know that the acknowledged, if you like, founder of the modern hospice movement was Dame Cecily Saunders. And Cecily Saunders founded St Christopher's Hospice in London. And she's written lots. I mean, it's fascinating to read a biography of Cecily Saunders. For me, it's just so fascinating that she was a nurse first, then a social worker, and then a physician. I don't think there's that many people who go through all 3 careers. But lots written about her, but this is my favorite quote. "You matter because you are you. You matter to the end of your life. We will do all we can, not only to help you die peacefully, but to live until you die." So now I want us to concentrate on dignity and person-centered care, and I'm going to give you some practical examples I hope people will feel that they can take back to practice. So dignity literally means the quality of being worthy of respect. And we know that all human beings are born free and equal in dignity and rights. Another quote from somebody who was involved in early hospice movement. Those are the cloisters in my university, so those people who are interested in Hogwarts and Harry Potter, one of the most beautiful bits of the university where I work. "We emerge deserving of little credit, we who are capable of ignoring the conditions which make muted people suffer. The dissatisfied dead cannot noise abroad the negligence that they have experienced." Key part of the work that I'm interested in dignity is this concept of legacy. So it's not just what you leave in your will, it's what you leave of yourself. And I think that's really, really important when we're thinking about end-of-life care. And in personhood, we think we do person-centred care. We have a whole department in our Scottish Government around person-centred care, and yet I don't think we really, really do that, not just in long-term care, in other areas as well. So this is elements of human beings that make them a person. It's a status given by others, assuming recognition, respect, and trust. And personhood made up of personal, relational, existential, and moral elements. So this lady on the left, she's so worried that people won't remember she doesn't want to be resuscitated, that she's actually had it tattooed on her chest. And then I think the other image, is an example of not good, not dignified, undignified care, long-term care. These images, I think, are more respectful of the elderly person, the senior, as some people would say. I'm not saying we all have to hug our patients, but this concept of touch, which we've already talked about this morning, is so, so important in person-centred care. So this is an example, a really easy example of person-centred care. What matters to you? So instead of asking what is the matter with you, we ask what matters to you. So this was a concept that actually came out of the United States, and spread, if you like, by the Institute of Health Improvement in the United States. But it came to Scotland by 2 of my colleagues. So Jen Rogers is a paediatric nurse by background and is now our Deputy Director of Community and Corporate in Glasgow, and Geraldine Marsh, who's an elderly care nurse, and she's now Chief Nurse in the south of Glasgow, our largest area, including elderly care. So this is some of the work, and they've spread what matters to you all over Scotland, and it's now something that's housed in our Health Improvement Scotland. So the example that you've got there is an example from Geraldine. So this was an elderly man in one of our elderly care wards in Glasgow. So he says, first of all, the things that matter to him, and then his family have added to it. So really, really important is what he's saying he likes to eat and drink. So Iron Brew, so those people who haven't been to Scotland may not even know what Iron Brew, but it's the national drink in Scotland. People think it's whiskey, but it's actually Iron Brew, so a fizzy juice, and it says he drinks Iron Brew for Scotland, interesting. It says, and I love this bit that his family have added. He's got a gift for rocking babies to sleep. He says a really, really important person is his granddaughter Jennifer, and she's written Best Grandpa. So we wouldn't necessarily know this elderly man with cognitive impairment unless we actually ask people what really, really matters to them. In Scotland, we've noticed when we do this properly, we need good communication skills to do this well, that people received care that was more representative of their individual needs. Health and social care services were delivered more efficiently, and staff members experienced more job satisfaction. So, so important. An example from my colleague Jen, from pediatrics. So this was a child being cared for in one of our pediatric wards, and he's saying what matters to him. So he's saying no moaning. I like that one best. Knock before you come in my room. How many health professionals, not just nurses, don't knock before they go into someone's room? And I always say to students, if the curtain's round the bed, you still knock. You don't just barge in. But also, because he's in an individual room, this child, he's saying, not before you come in my room, but don't forget about me, and have activities for me when I'm stuck in bed. And this is the atrium of our Children's Hospital in Glasgow, and we've got you can see the big balloons of what matters to you. It's something that we try and accentuate across the whole of our hospitals, not just it started off in pediatrics and not just in elderly care. But actually, getting people to do it all the time when people are busy can sometimes be difficult. This is actually something that came out of What Matters to Me, that actually it's called V-Create, using video to help parents of neonatal babies. This was before COVID. In all our hospitals, we used iPads and videos when families weren't able to visit. But this was before that. So it helped families so much using videos of babies when they were in our neonatal wards. So I just thought I'd rather like this slide. Life's so much brighter when we focus on what truly matters. So I'm just going to give you some more examples of practical examples of dignity in end-of-life care. So this is a model of dignity which came from a colleague of mine who's written widely around dignity, Harvey Chochnov. So Harvey is a professor of psychiatry in Winnipeg in Canada. And so this was the first really big piece of research that he did around dignity. So he did a piece of work asking people who were terminally ill what mattered to them. And this is the model of dignity that came out of that work. And it's still one of my favorite models because it includes not just illness-related concerns, what he called dignity-conserving repertoire, but also social dignity inventory. And one of my favorite things is in the last column, quite a Canadian term. In the UK, we wouldn't say this quite like this, care tenor. I would translate that into the UK language as the tone of care. How you approach somebody, how you are as a person, matters just as much as what you say. And sometimes for our elderly residents and people that we're caring for, sometimes it's what they don't say matters as much as what they do say. And another key thing, when people are dying, it's not always the pain and the distressing symptoms that matter to them. Health professionals, nurses and doctors often focus on distressing symptoms. Often people are worried about being a burden to others. So we need to find out what matters to people. When Harvey designed his model, he always said that there would be clinical approaches from that model. So I'm going to give you some examples of clinical approaches. So this is something that I invented, if you like, and I invented this for nurses to use, and particularly community nurses, to help them understand their patients better and give truly person-centered care. When I did this first piece of work, which is well over 10 years ago now, we actually did the first piece of work in rural Scotland on purpose. So we chose rural Scotland because the people, the patients, were far from a cancer centre, far from a hospice, and so that they were being cared for mainly by GPs, so community physicians and nurses, district nurses. So this is that's a little bit about how we developed the model. So I'm going to go on to the next slide, just careful of time. So when we were developing our intervention, we on purpose took on board the knowledge of the people in the area. So the nurses, the doctors, and importantly, the patients and the families. So what we ended up with as our final intervention was very, very much including clinical knowledge, evidence-based guidelines. Obviously, the evidence was important. Research or empirical knowledge, but also local context. So we have now done this work. We've spread this work to Ireland. We also conducted study across mainly rural Ireland, but also urban areas as well, but also Sweden as well and other areas. So we've done research work in all these different areas. I'm just going to show you just some examples. So in our intervention, in this intervention for people, so this is anybody who we think might be in the last months of life, including the frail elderly. So it's anyone that the nurses or the physicians think is possibly in the last months of life. Doesn't really matter if they get it wrong. The intervention doesn't hurt to use if it isn't, exactly the last months of life. So what the nurse does is that they use what this is called the patient dignity inventory. So they ask the person these 26 issues, and the person who's the patient rates it from number 1, not a problem, to 5, an overwhelming problem. And we say to the nurses, if the patient has rated whatever the issue is as 3 or more, then you take that further. You do something more about that issue. So the issues raised, so those people who can't read the English on the slide, they range from experiencing distressing symptoms, feeling anxious, through to feeling that life no longer has a meaning or purpose, feeling that my care needs have reduced my privacy. So the person needs to be able to engage with these questions to answer them. But we have found when we've used this and tested it, it works for a whole host of people. The person can either read the questions themselves or they can be read aloud to them. When I've done it with patients, I often read the questions out aloud and ask them what their rating is. And then what we've done is that we've designed some suggested reflective questions that the nurse asks the person depending on what the issue was. And then we've got some suggested care actions. Now, the nurse doesn't have to use our suggested care actions, but what we say is our care actions are from both what people have told us, but also from the evidence. So some of them might seem fairly obvious, but I can tell you when we've evaluated this, this is so important to the people who are being cared for. So sometimes it's using, that was an example of distressing symptoms. I'm going to give you an example of, so this is an issue that the patient had rated more highly, feeling that how I look to others has changed significantly. So we're saying treat the patient as normal with regard to the nature of the person, their feelings, their individuality. Acknowledge real changes and coping with them. Support the person to maintain their simple routines. Couldn't say the word simple then. So a big one for people at the end of life is that they don't feel worthwhile or valued. And what we've said is that the care action could be being there with the person. So this concept of the being there, we talk about in end-of-life care. So that's being alongside the person without necessarily having to talk. It's actually harder than you think. And it does require some time because it's literally being there with the person, letting them know that you're caring for them. It's no good just to think that the person knows that you're caring. They need to actually see that and hear that. Treating the person as an equal. Stop having this barrier that I'm the important one. No, the person who's the patient is the important one. And helping, I'm sure you do this in your long-term care, but sometimes I think we forget in end of life how important simple routines are. The very first time I ever worked in a hospice, I was a fairly junior nurse. But I was really, really struck by, and really loved doing it, making sure that people had still their individual needs respected. So I remember looking after a lady, and she still liked her dram of whiskey every day. She still liked to get her hair done. It was really, really important to her that she still wore lipstick and her nails done. And I promise you, up until the day she died, she was still wearing her lipstick. It was so, so important to her. We need to remember what's important to people. I'm aware of time, so we're just going to skip through some of these. So what we did in this intervention, though, we didn't just stop at the care action. We say it's a circle of care, and that we assess, we check out all the time whether what we're doing, what we're saying we're doing in our care actions is actually okay with the person who's the patient and, where appropriate, their family. So we found, though, that it did require, I think that it's not a difficulty, but the importance around when we're trying to do dignity and personhood interventions, it does require us to have good communication skills. And I think sometimes that gets lost in sort of elderly care and social care, how much we need to value the person who's the carer and help them develop really good communication skills. Our intervention does require the nurse to be able to identify when someone's in the last months of life. And it does, end-of-life care is around good multi-professional care, so it does require collaboration of staff. But what I think is one of the important things is what nurses told us, is that it recognised the valuable role of the nurse in end-of-life care. Obviously, carers are really, really important, but this intervention was specifically around nursing. I think we'll just start to round off now because I'm aware of the time. So as I've said, with this one, we did phase 1, 2, and 3 in Scotland. We also did a project in Ireland and a project in Sweden, and we do have plans to implement. So if anybody's interested in using this intervention, please contact me. Okay, I think I'm going to round off now, so I'm aware of the time, and I'm sure people are wanting their break. And also, hopefully, we'll have time for 1 or 2 questions if people would like to ask any questions to me.
Bridget, do you want to? The microphone's open. I know you have questions. We can't go to coffee until we have a couple of questions. Please. So, Bridget, I'll ask you the question. The dignity scale that you mentioned, the inventory, and the care plan related to that. Maybe can you give an example where you saw that happen and you saw that somebody maybe previously was struggling with their situation from using that intervention really made a difference?
I'll give you an example. And one of the things that I wanted when we designed this intervention well over 10 years ago, I wanted to make sure that people used it, not just with people who traditionally would be going to hospice, with people who were, for instance, frail elderly. So I'll give an example of somebody that the nurse used the intervention with, who he didn't have any obvious pathology, but he did have a lot of care issues, so nurses were going into his home. But more than anything, he was, and we see this a lot, and I know this isn't just in Scotland, people quite socially isolated. So, people were dressing his wounds, he required eye drops, and he sort of on purpose wanted the nurses to come in. But when they used this intervention with him, one of the things that he missed more than anything was his hobbies, and he was quite immobile. So what the nurses did was they brought the garden into his house. So they used, I'm sure you all know what a window box is, so just a small window box, and he planted his own flowers, and vegetables was something that he'd run, and it was just miraculous. He changed so much. So it might seem something, you think, is that really a nursing intervention? But I can promise you, it was actually like what matters to you. It changed the life, if you like, for this elderly man who was very cooped up in his house. He was very lonely. He was quite immobile, but actually changed by having this window box brought to him by the nurses.
Bridget, can you talk a little bit about, because I think what matters most, many of you have heard of Atul Gawande's book, Being Mortal. If you haven't read Atul Gawande, Being Mortal, highly recommended. I think he was one of the brains behind that. And one of the things he talks about is, and palliative care is really all about this, is the trade-offs around curative versus quality and time. So maybe can you speak to that a little bit?
I mean, that's an interesting one, because I think many people think, and they think if it was themselves or a relative, that quantity matters more than quality. In actual fact, no. I think that most people that I've met or cared for or met in my research, that the quality of life is much, much more important than quantity. So I can think of a lady that I met actually when I was doing my postdoctoral study, which was a study around self-management in advanced cancer. So I met this lady, and she was living in Scotland, what would be called a condemned house. It was actually a block of flats that they wanted to pull down, but she refused to move. And she'd been a heavy smoker all her life. She had cancer. So she said she knew she was going to get cancer. I mean, she wasn't stupid. She said she didn't want any treatment. She still went to every doctor's appointment, every oncology appointment, but she didn't want any treatment at all, because she thought, what's the point? So, I mean, many people, and her daughter was quite upset that she'd refused treatment, but her daughter said one of her favourite things was going along to the appointments and arguing with the doctor who wanted to give her treatment. And so what she did agree to was hospice daycare. So she said she really loved going along. She wasn't a particularly sociable lady, but she went along and she liked doing, the activities that they were doing, which would be very similar to the activities you would be doing in long-term care for people, crosswords, having a cup of tea, this sort of thing. But she actually, and I think she was the epitome of somebody who had a quality end of life rather than quantity. She didn't need to add months and years. She didn't want to, importantly. The quality of her life was much more important. Seeing her daughter, seeing her grandson, and doing activities that she cared about.
Thank you very much. Fantastic talk. Well done. Thanks, Bridget. Fantastic. That's great.